Hi, everyone. Welcome to our session on COVID-19. Feels weird to be super bubbly about that, but I got nowhere else to go. So my name is Ian O'Brien. I'm the Deputy Executive Director of Free Speech Coalition. I've been working at Free Speech Coalition for the past 3 years. Mostly, I'm in charge of the PASS program. So we've been working in health for the industry for a little bit now, and really involved in our response to the pandemic. Dr. Tang, we contracted in the middle of the pandemic to kind of help us along with some questions that we had to get outside consult regarding the virus, some of our protocols, what testing might look like. And he's been instrumental in kind of keeping us informed of updates to the industry and kind of occupational health in general. Dr. Tang, is there anything else you'd like to say?
Just to say hello, everyone. My name is Chris. And just so you know my background is actually hospital medicine and critical care. And I've been living in the occupational medicine world for about 10 years now, working with large orgs across the nation, probably about 20 of the Fortune 200 companies now. And I've been working closely with them, advising them on response to the pandemic. I actually started with one of our multinational corps back in January with their Asia operations, and little did I know that we would be starting in the United States in March. And I've been living and breathing it along with all of us here. And it's a shared challenge that we all have as a group. I'm really excited to be able to work with Ian. Our goal has always been to give the best guidance from the medical perspective and do our best to integrate that into the operations of all of your facilities and locations. So I'm here to answer any questions, to serve more as a subject matter expert on COVID, whether that be about vaccines or processes or protocols or the science behind it. So I'll be here in the background supporting Ian and really happy to be here to help support our communities. Thank you.
Thank you. So my strategy for this session, as I've spoken with people over the last, 9 months now, there's a million questions. There's a lot of information out there about this because it's an evolving pandemic and a novel virus. There's a lot of information that's rapidly changing. In fact, I was literally on the phone before this talking to somebody about quarantine guidelines, and they were like, well, my doctor told me it was 7 days instead of 14. And it turns out the CDC updated their quarantine guidelines literally yesterday around how long people should be after exposure. So there's a lot of confusion, and people don't know what information to trust. They're having a kind of consistent response to that has been difficult. So hopefully we can use this session to answer a lot of those questions, give you where the science and information is currently at. I can answer things from FSC's perspective and kind of where we imagine the kind of structure of the industry going. Dr. Tang, like you mentioned, is here to talk about the specifics of COVID. And kind of the science behind it if we have those particular questions. So I just want to give a little bit of background of where we're at, then we can spend the most of this time just asking questions. We've been doing this since March, and the industry shut down for the bulk of April and May. I don't believe in being doom and gloom about public health situations. I don't think it's useful. That being said, the prevalence of this virus is higher than it's ever been, and it continues to climb. So the landscape of which we're dealing with is, while we have more of an understanding of what the virus is, we've definitely gotten better at treating it. How this is going to turn out and what that means is still, there's a lot of unanswered questions. For the industry itself, from the reports that I've received, there hasn't been a huge amount of danger on our sets. The incidents that we have had reported have been fairly contained. And it seems that testing has done a decent job, at least at catching things early. That being said, those are only the reports that I've received. And there's always a bias towards the data. Like, if something is bad, people are not going to come to FSC and be like, hey, like, we messed up. And so we want to, part of what I want to do here is say that, like, folks that have been following protocols and being informed and being proactive, getting regularly tested, following that PPE requirements, and keeping FSC informed of potential exposures, that's really been an effective way to kind of mitigate the spread of this virus within our industry. One of the biggest questions I get asked, and think there's a lot of challenges with, is testing around COVID. We knew this going in. We're an industry that is very used to testing. We knew that implementing testing for us was not going to be a significant challenge, because people know what that means. They know where to go to get it, and it become a regular part of a lot of people's work life. The difference between COVID testing and STI testing is that with STI testing, we really can account for a lot of the variables, right? We know it's easier to count the number of sex partners you've potentially had rather than the number of people you've just interacted with in a day. We know a lot of information about the STIs we test for, right? Like, HIV might be the most researched virus in the world. And so we know exactly what points to intervene, what the risk profiles look like, how it's transmitted, why it's transmitted. And so when we get an STI test, we can really confidently say, in this period of time, there's a very, very low chance of a potential risk of transmission of any of these viruses. For COVID testing, it's different. There's a huge amount of variables around potential exposure. It isn't isolated to just performers now either, right? Like, for the first time, we're having everyone on set get tested for COVID. And they're all interacting with different people, and it could spread at any moment. Not to make that scary, but COVID testing is an effective tool for screening, but it's not a panacea. And I think when I've spoken to people a lot, there's this belief that you have a negative COVID test result, it automatically means that this person can't transmit a virus for the 2 days guidance that we have. And that's not necessarily true. We have an additional piece of information that means that it's likely less risky than if someone didn't get tested, but it's not the same as an STI test.
If you want, Ian, I can elaborate on that. I think this may be helpful for everyone. This is really important to me, and I was just share a little anecdote. I live close to Melrose in Highland in LA, and I drove by a little urgent care there before Thanksgiving, and for the few days before it, there were lines like a block long, and I'm sure it wasn't to get their cholesterol checked for at the urgent care, and this was for COVID testing. COVID testing in and of itself is not perfect. For STI testing, we've had the opportunity to really perfect these processes over decades, and they're very highly accurate. The one challenge with the COVID testing is that it's a swab in the nose, and the virus level may not be high enough to pick up, meaning the copies of it. The person performing the testing may not go far up enough the nose or capture enough of the sample for it to be perfect. So there's a lot of variables in the testing, and a test in and of itself is not a 100% validation that you don't have the disease. It's a great tool to use, but it's one tool in the multiple layers that we're inputting in the processes, meaning screening for symptoms, distancing when we're able to distance, right? It's just one tool, and it hasn't really been published anywhere, but anecdotally, I believe that the false negative rate may be around 10 to 15% depending on the test. And it's not the test in and of itself, but the variables such as sampling and timing of the sampling that really throw off the accuracy of the test. So it's so important to have layers of protection. And this isn't just in the set per se. I really believe that we have a responsibility to each other. And most of the spread that I'm seeing in organizations and industries across the world is that it's happening in the communities actually at a much higher rate than any work setting, because in the communities, we're not doing a lot of the distancing, the mask use that we're implementing in many workplaces or sets. So we have to keep this in mind that what we do, there's never been a time in history that what we do outside of work has such an implication on what happens at work and the outcomes that occur at the set. So all of these things really need to be integrated together. And there is a flaw that the test is not perfect because of sampling challenges and timing of the test. So I hope that really works and gives you an idea of what the potential weaknesses are, because I think it empowers us to make the right decision. I saw someone put into the chat, hey, what about the rapid testing? The rapid testing probably is not as good as PCR, but the antigen testing is pretty good. Yesterday morning, the CDC hosted a call and they said that it's probably almost as good as the PCR. And I would probably agree with them. I wish I could give you the exact differences, but we don't know because it's so early in this pandemic from a science perspective. Normally we have decades of information. Here we're compressing that into months. So the new rapid tests do seem to be pretty good. Okay, so I'll hand it back to you, Ian, and hopefully that was helpful.
No, that was fantastic. That's exactly. I see a lot of questions about testing in the chat. So all the tests that we use are following regulatory guidelines. Currently, like Dr. Tang mentioned, we're only recommending PCR testing, though have been heavily looking into antigen testing for a while. PCR testing is the one that's conducted at all clinics. TTS, while they don't swab in the nose themselves, I believe they're doing an oral swab. Which is still testing for the same, using the same methodologies, just a different site of collection.
That is correct. And PCR is still the gold standard. It is better than antigen testing, even with what the CDC said they're pretty close. When I look at the level of viral detection, PCR is, in the scientific studies, it is much better. So it is still the gold standard.
So Alana, to switch to antigen, we've been looking at it for several months now. The benefits for antigen testing is it can be done faster. The turnaround time and the cost would likely be much cheaper, which would increase access to a lot of folks in the industry, because we know the current COVID test is a big burden. I personally have been wanting to integrate this in some capacity to our testing protocol. The challenges we're facing right now are a matter of resourcing and regulatory pieces. So I think it was a couple weeks ago, the Cal OSHA, which oversees occupational health standards in California, put out a guidance saying that the tests that they are requiring for or anything that has been approved by the FDA for diagnostic standards. We believe this to also include antigen testing. However, we're according to the lawyers that we've spoken with, currently only PCR testing is being used for work comp purposes. So if something happens on set and an antigen test was used as opposed to a PCR test, there's increased liability. We're still looking into what that could potentially mean, but the idea is to move to antigen testing or incorporate it into our testing protocol as soon as it becomes readily available and we've met all our compliance guidelines. Oh yes, Cora. So that is the CDC just yesterday. The question is about quarantine and guidelines or incubation periods for the disease. So up until yesterday, the general guidance was if you have been exposed to somebody with COVID-19, meaning you had close contacts for an accumulation over 15 minutes or up to 15 minutes, that counts as an exposure. You were to quarantine for 14 days past the date of that exposure. So if you were exposed on the 1st, you'd be in quarantine until the 15th. However, just yesterday, the CDC released guidelines saying if you reducing that to 7 days with a negative test result. So you get exposed on the 1st, you quarantine until the 8th, you get tested, and that meets their quarantine guidelines. Now, if you and 10 days without a test. However, they also say they're still fully recommending the 14-day window. They think it's the safest option, but the vast majority of risk would probably be mitigated within that 7
I can
days.
elaborate. I'm going to jump in here, Ian. I've been living and breathing this since this came out, and I've been kind of tracking the CDC. Actually, has been mulling this for about 3 weeks. I got wind of it about a week and a half ago from some of my contacts, and I've been tracking. And it's funny because I saw it released on all the websites before the CDC actually released it, which I found hilarious. It's almost like TMZ. I found out about the Kardashians before they actually come out saying anything about it. So finally, the CDC officially came out last night on their website saying that they still recommend 14 days, but there's an option to return people back at 7 days if they have a negative test at day 5, okay, or at 10 days with no test, that these are options, but that we should also follow local health guidance, which takes priority. And I know in many areas, the local health guidance, like the LA County Department of Health, Alameda County, and I'm looking out of state in Colorado, all across the nation, they actually haven't caught up with the CDC yet. But even though they've said these 7 and 14 day options, they've also said there's inherent risk. So with the 7-day option with the test, there's a 1 to 12% chance of failure. And with the 10-day protocol, a 1 to 10% chance of failure. And is that something that we are willing to risk or live with? So for example, if we clear 100 people and we use the new 10-day protocol without a test, somewhere between 1 to 10 of those people will fail and will likely have the disease and pose a risk to others. And that's something that I'm working with many orgs, and I haven't spoken with Ian about this in depth because it just came out yesterday evening, but there is inherent risk with using these new protocols. And is that a risk that we are willing to live with? So in all transparency, that's something that we're going to have to debate, but while also looking at local health guidance at the same time. So hopefully that brings as much clarity as mud for everyone. But I did want to just share what the true medical side of this is going to be, that there's inherent risk with those protocols. Thanks, Ian.
Yeah, so we're definitely going to be having I expect that to be a robust conversation. I was speaking to people again just before this call who had potential exposures, navigating whether or not they're going to do it for 7 days or 14 days. I expect to someone's question right here, how do we balance personal liberty? It's all a give and take. I don't think there's a clear answer here. my background actually, and why I got into healthcare is in healthcare ethics. So those questions are like really near and dear to me. Like, how do we force a rule on people for the sake of a greater good? What does that greater good mean? And does that outweigh the kind of like burdens on individuals? And I think, and this is something that's been being grappled with around the world, right? Like, it's obviously an enormous debate within the United States, and particularly contentious. We've got a lot of love of liberty here. And I think in an occupational setting, if we're going to reduce the scope and think of ourselves as an industry, as an occupation, the part of our challenge, right, is that folks need money for survival, and we don't work in an industry where there is a lot of folks with access to paid sick leave. Like, if you can't work for 7 to 14 days, that means something incredibly significant. When we put out the emergency fund earlier in the pandemic, the idea was to mitigate at least some of the challenges faced by that. But that we don't have list funds for that. We can't fundraise endlessly for that. We can keep trying, and I think that's an important strategy. But really thinking through those options. And for me, kind of where my philosophy sits for this, and as we design protocols for the FSC, is you can't be healthy if you are also poor. The poverty in the United States is real. Not being able to access healthcare or housing or food is real. And we need to maximize the ability for people to continue to work and continue to generate income for themselves, while protecting as many people as possible. Because that also, spreading the infection does not mitigate their like other folks' ability to access revenue. So those are the really big tensions here. I think as an industry, we're really good at navigating risk, right? One of our biggest sticking points around Prop 60 was the ability to bodily autonomy. And we have a right to choose what we want to do with ourselves and how we navigate sexuality and the workplace. And enforcing rules that don't work for us are not effective. We know what our intentions in getting to a relationship. And so that's our starting point. That's how we think about solving these problems. How do we protect ourselves as a community? How do we talk about communicating risk? How are we open with this? And that's how I think we should navigate there. Colin's question, central repository for COVID stats. So the past system does accept COVID test results, and only COVID test results as well. Like, meaning we're still accepting STI tests, but if you get tested for COVID using a PCR test, and it can be input into our system, that will display. We updated that back in May or June, I believe, whenever the industry had just reopened. And we're constantly looking to onboard more COVID clinics. I think part of the challenge for us in spreading access specifically to PASS has been a volume issue. Like, we can't commit to these clinics. You're going to get an X number of people every week, right? Because like FSC doesn't control anybody's working environment. We just facilitate the database and act as a clearinghouse for that. So we're continuing to onboard that. I think it's going to be, COVID has forced us to reimagine what PASS can and should be, really, in order to adapt to multiple people's health needs and really serve as the database that we need to be. All right, did I miss any questions? not sure what TTS is doing with their database currently. We are planning on keeping PASS open. And we even kept it open during, a big elephant in the room with the new orders that California stay-at-home orders and LA's more strict stay-at-home orders is the industry going to stay open? So our guidelines and whether or not we announce a closure of the industry in relationship to COVID-19 has been whether or not there's regulation around it. So when we closed earlier in this year, it was because of California's guidance around closure. And we know we're not all California, right? Like FSC is based in California. A good bulk of the industry is in California, but we also have large populations in Las Vegas and Nevada, Florida, but also all over the place. We've been following California because one, where we're headquartered, two, it's usually the most conservative option in relationship to public health. Though we're working on getting more nuanced in our responses to what that means. So the industry is current, but even when that shutdown occurred, we kept PASS open. And the idea was, personally, I don't want to punish people who need a tool to maintain their health, who have to navigate working in this pandemic. It wasn't safe to work that time. I don't want to say FSC's official stance is that you shouldn't be working when the government says you shouldn't be working. But I'm not going to take away a health tool during that. And looking forward, the LA has made no claims that the industry that would affect the industry shutting down in the near future. However, or at least their most recent guidelines doesn't suggest that. However, they said as rates continue to rise, things might change. We don't know exactly what that would look like, but we'd follow whatever they do. We frequently look to Film LA as well as an organization because no one ever addresses adult production directly. We kind of have to insinuate what they're talking about. So if general filming is open, we'll keep the industry open and keep pushing precautions.
And maybe I'll just jump in. I flipped through some of the chat as Ian was talking, and I just want to kind of address some issues or questions, not really issues. One person asked if, is it really something to be concerned about when, you may have a potential 2% mortality and only 5% of people may be hospitalized? My belief is this is a true concern, and for so many reasons, from the health perspective, from the economic perspective. As Ian mentioned, there's a lot of social challenges that are born out of this. When I first gave a talk at probably a Fortune 10 org in February, I crunched my own data about mortality rates from the cruise ship off of Japan, where people have COVID. And the mortality rates that I came up with were about 0.5 to 1% of people pass from this. And after I gave this talk, which was actually shot out to probably about a 98,000 person workforce, the WHO released that the death rate for this was 3.4%. And I got destroyed in social media that day. I remember I got phone calls from like the CEO, like, oh my God, who's this guy you brought in to talk? And he came up with these numbers. As we look at it now, the mortality rate is probably it's definitely lower than what the WHO said. It's probably maybe a little bit higher. Young people, the vast majority do get well. The elderly and the people with comorbids, they have a really high mortality rate from this. And in some age groups, it might be as high as 10 or 15%. So we're not just looking at us and about ourselves, but actually, our families and our friends and the elderly who we do interact with, like, potentially over Thanksgiving, especially if we were a little bit looser on our activities. And it's not just the health that it's very serious, but as our hospitals become overrun with COVID, they don't have the resources or beds to take care of other patients. I've been tracking the hospitalizations in the largest hospital group in Southern California, and our COVID hospitalizations are the highest that they've ever been since the pandemic. Our ICU and ventilator utilization is just lower, but that is a lagging indicator from hospitalizations, because first you're hospitalized, then you end up on the ventilator. And we are single digits off the peaks that we saw back in April. So we're very, very close to that. So it is a very serious concern, even though the vast majority of people get healthy. And in kids, a lot of them do really well. When we finally look at the data of this, I truly believe inside, and I've been speaking with pediatricians, that the mortality rate in kids may be lower than the flu potentially. It might be lower than the flu, but that does not mean this is a disease to be trifled with. So I just thought I'd share that. Someone asked about travel in summer. And I think that that's important as we make plans for the future. I saw someone mention COVID fatigue. It is out there, and I'm seeing spread because people are sick and tired of wearing these and staying apart. It is not part of our nature as a society to isolate. We're very social a species, I believe. And let's talk about, before travel, there is going to be inherent risk, about vaccines for a second. I do not see a widespread distribution of vaccines before first to second quarter of next year. We're probably going to start seeing some distribution mid to late December for some critical groups, but we're not going to be seeing widespread distribution. And even with the widespread distribution, there's about 40 to 50% of people who say they don't even want the vaccine, right? So these are not going to go away, because if we don't get vaccinated, there's still going to be a large proportion of people who don't have immunity to the disease. So when I'm looking towards June and summer travel, I'm not saying don't do it. I'm a big believer in freedom and making the right choices with the right information. There's still going to be inherent risk, I believe, at that time. I believe it'll be much lower than now. I do not believe we'll be away from the masks, and it's going to depend on immunization and how far and what percent of the population ultimately get it. So that kind of looks at vaccines. Someone talked to me about what's best practice in your industry versus benchmarking against other organizations. I can honestly say that you are probably doing more with the testing than almost every other industry out there. The one thing that you're not doing probably as well is distancing, depending on the shoot, obviously, because there are things that there are differences. I'm just being very honest here, that there are differences. But as far as like testing and protocols, you are probably on par with best in the world, or even better than best in the world, except for that distancing part. But that's part of the inherent risk, and to make the right choice for yourself, and we will continue to give the best medical advice. So just thought I'd share that with you. I wasn't able to track. I saw a lot of things get typed along the way, but maybe I'll just take a breath right now. I'll review some of those and hand it back to Ian.
Thank you so much, Dr. Tang. With regards to vaccines, FSC is definitely watching the development closely and thinking about how we might implement that as they become efficacious and available as part of our protocol. So from a different than a population level approach, focusing on an occupational, PASS currently, PASS has toyed with the idea of vaccines before, right? Like there's, I think it's hepatitis B that we talked about. Hepatitis B, we don't test for hepatitis A currently, but also thinking about including that and what that might look like as part of a protocol, so that folks don't have to test for that specific part of the panel every time if we know that they've been vaccinated within the next amount of time. So we don't know how that would look like exactly. There's definitely different HIPAA concerns in relationship to, so right now the way the PASS system works is you've got just a green check or a red X showing pass clearance, because we don't want to give out specific medical information, because that requires medical record keeping requirements, of documentation and vulnerabilities to people's health information. And a vaccine would kind of change how we would have to display data. So we need to think through what that would look like, but it's definitely a possibility. And we want to make sure it happens. All right, let me look.
So I'm going to jump back in about the vaccine. The vaccine, I don't believe, is going to create super spreaders. The vaccine should help mitigate spread, because a person who's vaccinated, the virus should not be able to replicate in their body. And if the virus isn't able to replicate in that individual's body, then they won't be able to spread it. A vaccine is almost a way to fast track us to herd immunity, which is when enough people are immune from the virus, it won't replicate in those people, and those people can't spread it, right? So I do not believe that the vaccine is going to move to create super spreaders. It's actually going to help prevent people from getting the disease. And if you can't get the disease, you can't spread the disease, right? Same with anything else. If you can't get it, you can't spread it. So really important. The vaccine looks highly effective right now. I believe the numbers are going to diminish a little bit over time. I mean, we're talking 90-95%. That's unheard of with many vaccines. But the follow-up on these people in the studies, and they're huge studies, like Moderna, I think, has 30,000 people, and Pfizer has 40,000. They're robust, but they've only followed people a very short time after that second vaccine, let's say arbitrarily several weeks now. So we don't have the full data of how effective it is. I do expect those numbers to drop a little bit, but it is looking very, very positive for all of us. About mutation, there's the risk of mutation in any virus. And that's what happens with the flu. Every year, there's a different flu vaccine, right? Because the flu virus jumps from northern hemisphere to southern hemisphere, and we have to remix the vaccine every year to try to match the flu strain. There is the possibility for COVID to do that. If I had to guess, it is most likely that COVID will become one of these flus that may spread around in small pockets, but not be as widespread as it is now, because that's actually how most of the circling flus came about. We have about 4 to 5 circling flus each year, different strains, and I believe that the coronavirus will become one of them, but I don't believe it's going to have this level of devastation in the future because of the vaccine, because a certain amount of people will have antibodies to it because they've been infected already. So we move toward this herd immunity where there's, let's say, 80-90% of people can't be infected by it that much. They just can't spread it like they are now. So hopefully that answers some of the questions around the vaccine and potential future with mutation and flu. And just so you know, if you know, there's vaxxers and there's anti-vaxxers, and I believe in vaccines. Okay, this vaccine, it is going to cause a local reaction, and I think that's something to be very aware of. That I'm talking with organizations when we ultimately do roll out the vaccine, such as critical infrastructure, to do a phased approach, because they're finding potentially 5 to 10% of people get flu-like symptoms with the vaccine or a local reaction. And it's not the disease, but this is your immune system reacting to build up the antibodies so that if it ever gets you, it's not going to kill you. And that's really powerful, actually, because people say, why am I going to get a vaccine if I'm just going to get sick from it? Well, what they found with the Moderna vaccine is that when people got it, they had this reaction, but no one was dying. People are dying from COVID. So be aware that if you ultimately choose the vaccine, it is common, probably 5 to 10% of the population will have some sort of reaction, but this is your immune system building up the antibodies so that you will not get super sick. So I think it's really powerful to have that information so that there's not misinformation spread that I got COVID from the vaccine. Okay, so I'll take a moment, step back, and try to process any new questions and hand it back to Ian.
Thank you, Dr. Tang. And then just a comment about mutations. Like a well-known example is HIV, actually. So there's actually two types of HIV, or more complicated than that, but two major types. HIV-1, which is the one that's most prevalent and the vast majority of people have, and HIV-2, which is a mutation of HIV. Is detected in a similar way, but almost exclusively isolated in West Africa. Of course, there's folks with it outside of West Africa, but the vast majority is in that space. So mutation, I think, has, I bring that up to say that we're well aware that these things occur, but we know what they mean, and it's not as devastating as I think it's frequently presented. They do increase additional challenges, but the kind of biology of the virus remains very similar most of the time. So we're able to tackle those challenges most of the time. All right, I'm going to find, did I miss somebody's question?
Yeah, that would be great. If your question hasn't been answered, if you could maybe pop it back in to refresh. There's been quite a few pop through.
I know, and I'm the worst multitasker. I will take this moment while we're waiting for folks to re-ask questions. So there's this big tout for the pandemic around personal responsibility and how we all have to operate individually in order to prevent the spread of the virus, which is absolutely an important focus of this. But given the history of FSC, given the history of the industry, there's also an important governmental advocacy piece here, right? I think sometimes we talk about individual responsibility to distract from the fact that there's been a failure at multiple levels of government to contain this virus. And while our hospitals are overburdened due to incidence rate, we need to think about how that occurred so easily. Why do we have such a minimal number of hospital beds and access? Who is getting access to care? Where is this occurring? And really think about how we want to change our system. So this is my soapbox moment to get on and be we need healthcare for everyone. We need to rethink about how our hospital systems work. And we should be really asking more of our government officials to serve and protect us. All right.
Okay, I'm going to jump on a couple. So vaccine choice. The vaccine and how it's really going to be distributed is still black box to me. The CDC and federal government are going to make their recommendations on who it goes to first, being healthcare providers on the front lines and potentially the elderly. And then after that, it's actually going to be up to local and state regulators on how they want to distribute the vaccine to various medical clinics. And we still have to wait to see whether Moderna or Pfizer will ultimately be approved by the FDA and how that's going to be distributed across the country. I'm not going to go into the details during this call, but there are some major challenges even with the logistics of moving the Pfizer vaccine because it has to be stored at -70 degrees Celsius, which the next closest commercial vaccine is -20. So there's a lot of challenges. So I don't think you'll necessarily have the choice of which vaccine you get. And that's my belief, and it's going to depend on the regulators on that. Someone asked about whether whether they're doing studies on seeing if people can transmit the virus after the vaccine. And I would say that, I don't think that there's any studies actively that I'm aware of that looks into that. But typically when someone is vaccinated, the virus is not able to replicate successfully in the individual. And this is looking at other illnesses and all the other viruses that we have in the past. that they normally don't spread the virus if they're vaccinated. Like, for example, hepatitis B, I'm vaccinated for it. Even if I'm exposed, it is very unlikely for me to be able to spread it to anyone else because the virus can't come in my body, replicate, and for me to secrete that in my bodily fluids to someone that I touch or come into contact with. And our assumption as a medical entity is that COVID will react the same way. If someone is vaccinated, they can't serve as a host for that virus to replicate. So I would be fairly confident in saying that someone who is vaccinated has a successful immune response, meaning that your body builds up antibodies, will not spread the virus very well. There's a few caveats, remember. The virus, the vaccine effectivity rate right now looks about 90%. That means 1 in 10 people will not form an immune response. Those people will not only be susceptible to the virus, but those people will also be able to spread the virus, okay? So that's kind of the take on it. The second part of this that we don't really understand yet is how long the immunity lasts. Right now, there's some studies say, hey, it could last 6 months, 9 months. No one really knows. This is a lot of wet thumb in the air, to be honest with you all. And we don't know that question, how long this immunity lasts and how long it'll keep us from being able to be infected or to spread the virus. Okay, so hopefully that helps. Someone asked about placebo, which is a very interesting thing. The people who got placebos in the studies, this is an ethical issue with any vaccine study, is if you know the vaccine is successful, you should give it to the people who receive the placebo fairly rapidly, right? Always the challenge in medicine is as we give the actual vaccine to the placebos, we're not able to follow these two groups 1 year, 2 year, 3 years down the line to start looking, hey, is there any differences in outcomes between these two groups at 2 years? Are there any side effects that you see 2 to 3 years out? And that is one of the challenges. But we also know we're dealing with a pandemic that is very dangerous to a lot of people. So I just thought I'd kind of introduce you to some of the challenges we face in looking how the vaccine is going to be thought of and analyzed moving to the future.
Fantastic. Thank you. Thank you. So we're out of time for our session. I know there's a ton of information. I want to thank you, Dr. Tang, for being willing to join us here. It's a huge benefit to have somebody with your expertise be able to talk directly to the industry. I know on an FSC level, we've greatly appreciated being able to reach out to you and confirm and ask questions about what's happening. If any of you have any further questions about COVID, FSC, PASS, or the industry in general, feel free to reach out to me. I'm Ian at freespeechcoalition.com. If you go to the freespeechcoalition.com website, you'll be able to find me. I'm also on Twitter. I'm mostly just obnoxious and tweet pictures of my animals, but I'll answer you there. It's Ian T. O'Brien. We also are going to have a town hall. We were supposed to have it tomorrow, but we're going to reschedule for next week due to more information coming out next Friday at 11 a.m. to 1 p.m. Pacific time. And we'll put out a press release about that shortly. But thank you all for being here.
I want to just throw one last plug and thank you so much for your time sharing it with me. I do want to just say I really believe that we have a responsibility to ourselves and a responsibility to each other to do the right thing. I believe most of us know what the right thing is, and what I found during this pandemic, for myself personally and the people that I support, is that the right decision is often the hard decision in this, and a lot of people who've made the missteps are unwilling to make those hard decisions. And I encourage you to look deep at the information that we have that is true and correct, and to do the right thing for yourselves, your families, and society. And thank you again, and be safe. Okay, I'll hand it back to you, Ian.
All right. It's a perfect note to end on. Thank you, everybody. Stay safe. Have a wonderful rest of your week, and a wonderful rest of your year. To 2021.
It will be
May
better.
it be better.
Take care, everyone, and be safe. Okay.
It will be.
Bye-bye.